Alright, so picking back up with chapter 50, venous thromboembolism, that is a blood clot. You may also hear that abbreviated as VTE. Now, DVTs, deep vein thrombosis, and PEs, pulmonary embolisms, are subcategories or forms of VTE, or venous thromboembolism. Now, patients that undergo surgery for more than 90 minutes, surgery of more than 60 minutes that involves the lower limbs, and those expected to have decreased mobility after surgery are at risk for a venous thromboembolism. Now, deep vein thrombosis, or DVTs, we see that those are a risk factor after surgery, especially if a patient has had surgery on their knee or their hip, which affects their mobility. If your patient obtains a DVT while under your care, insurance and Medicare do not cover the cost associated. Okay. Now, when we talk about, we're switching gears here, I'm going to switch to cardiac history. When we talk about assessing or interviewing a patient, we want to ask them, do you have a history of chest pain? Which medications do you take for your heart? You want to make sure they're rating their pain on a scale of 0 being no pain at all and 10 being the worst pain they've ever had. We want to see if they can describe their activity level, okay? We want to know, when does their pain start? How long does their pain last? What alleviates their pain? Okay. Now, it's important to also know about allergies, okay? It's important to know food allergies because chestnuts, bananas, kiwi, and wheat, just to name a few, have a cross sensitivity to latex, okay? We want to make sure that when we're prepping, we're going to switch back over to prepping. So when we're prepping these patients for surgery, we want to make sure we're asking about those allergies as well. We want to make sure that they've discontinued all their anticoagulants at least 48 hours before that surgery. Now, if a physician might want someone to be off their anticoagulants for 7 days prior to surgery, okay? So some physicians want longer time frames. Now, chronic use of steroids, that increases a patient's susceptibility to skin tears, to whereas older adults are susceptible because of the decrease in the epidermis. Okay. Now, we want to make sure that we're assessing breath sounds before and after surgery. And to go back with the DVT prophylaxis, we want to make sure that the patient has an early ambulation. We want to make sure that we're using that incentive spirometer. We're having that patient turn, cough, deep breathe. Okay, these are all things that are going to help to prevent a VTE and to prevent pneumonia. Okay, so I do want you to know the BUN, or the blood urea nitrogen. If the BUN is low, that can be from liver disease or fluid overload. If it's high, it can be from renal or kidney disease and dehydration. Okay, creatinine. So if our creatinine's low, that can mean malnutrition. If it's high, that can mean renal disease. Okay, now BUN, normal value 10 to 20. When we talk about creatinine, 0.6 to 1.2 is male and 0.5 to 1.1 is women or female. Now, it's page 1274 in your book. There is a list of INR, PT, PTT, and activated PTT. Okay, I do want you to look over those and have a good indication. There's a pretty little table. It is table 50-6. It's labeled Common Laboratory Tests for Surgical Patients. Okay, so if these levels are low, that means the patient may be at risk for clot. If these levels are high, that means the patient may be at risk of bleeding. Okay, so when we talk about different types of anesthesia, we have general, we have regional, we have local, And we also have moderate sedation. Now, general anesthesia is when a patient loses consciousness and reflexes. That general anesthesia is typically given through IV and inhalation for pediatrics. Now, the risks associated with general anesthesia, we can have laryngospasm, hypotension, hypothermia, aspiration, cardiac abnormalities. Okay? With regional anesthesia, this results in the loss of sensation to an area. So elevation of the upper body helps prevent respiratory paralysis. This is referred to as a block. Okay? If a patient has a block, you have to monitor their function and sensation. Typically, the blocks are used for patients who cannot undergo general surgery. They are not well enough to undergo general surgery. So risks associated with regional anesthesia, we have respiratory paralysis as well as the injury to the spinal cord. Okay. Local anesthesia, that's whenever we have a loss of sensation at the site. So if you go to the dentist and have to have any work done, they provide local anesthesia. Maybe you've had a gash in your hand, they use local anesthesia to sew that up. Okay. The risks for local anesthesia are anaphylaxis. Now, with moderate sedation or conscious sedation, that's used so that patients have a depressed level of consciousness, but they don't require ventilation or they don't require the need to maintain a patent airway. A breast biopsy or an upper GI or a lower GI would be examples of procedures that typically use the moderate sedation. Okay. Now, risks with moderate sedation, we can have aspiration as well as respiratory depression that can occur. Okay. I do want you to look on page 1285 at the post-op area. Now, on page 1285, there's box 50-7, and that's the initial post-anesthesia care assessment, parameters to assess. So I do want you to look at that. Now, if you didn't catch anything I said with general, regional, local, and the conscious sedation, there is a table on page 1284. It's table 50-7. Okay. I do want you to look at page 1288 for malignant hyperthermia. It's in that left-hand column. I also want you to look at page 1291. And there's a table 50-8, and it starts on 1291, table 50-8, and it's continued on to 1292. Okay, and that is a table about post-operative complications. All right, and that is the end of chapter 50, care of surgical patients.